when we listen to stroke survivors that have had a clear correlated risk factor, they say to us, why didn't someone tell me in my, my experience with a healthcare worker that I was at risk of having a stroke?
Yeah. Hi everyone, thanks for tuning in. In this episode, I'm going to interview Dr. David Hargroves about stroke. Now, since I started this podcast over a year and a half ago, this subject has attracted by far the most listener questions and the most listener interaction. So I'm very excited about this, and I advise you to please stay till the end when I'll ask these questions, because these questions are so insightful that I think you'll benefit from them. So David is a consultant stroke physician and national clinical director and Getting It Right First Time national clinical lead for stroke. He's active in research, widely published, and committed to education. He is highly regarded, and he received a Professional Excellence Award from the Stroke Association. I'm delighted to have him on the show today. David, welcome. Thank you so much for joining me today.
Thank you ever so much for having me, Gail. We're really looking forward to this, and it's a great opportunity to discuss all things regarding stroke and how we can help patients in the future.
Yeah, absolutely. So, David, I find it fascinating to learn why high-flying colleagues like yourself chose the particular area in medicine in which they practice. So, can you enlighten us? What made you interested in going into stroke medicine?
Thanks, Gail. Isn't it interesting how we choose our specialties? So, of course, I think you're a gynaecologist.
Yes.
And
Yep.
all the way through medical school, I was pretty confident that I wanted to be a physician. And so for your listeners, they're doctors that make diagnoses and use tablets and medicines to help patients. So I was pretty confident I wanted to stay in hospital medicine. And interestingly, I thought originally that I wanted to be a cardiologist. And I started training to be a cardiologist. And it was during that training in northeast London that I had an opportunity, purely because that's the way the rotations were, to spend some of my time on one of the first stroke units. And it was whilst I was there that it dawned on me that I was seeing a group of patients and working with a team that were second to none. And the multidisciplinary working, the opportunities that were just starting to exist in stroke medicine. So I don't mind showing my age here. So this is the late 1990s, and we were just at the start of organised stroke care within England. And we were just seeing the first few stroke units being developed. And I was fortunate to work on one of those as half my time as a cardiology junior doctor. And it was during that time I thought this actually is the group of patients, the families, and the team that I would like to work with. I mean, I think it probably helped that at medical school I integrated a BSc in psychology, and so I was really aware of the other aspect of healthcare, as opposed to the physical symptoms, but the psychosocial and the psychological sequelae that often goes with physical ill health, and how important that is as part of a patient's recovery journey. So it all conspired for me to change my footing and start a 6-year training program within geriatrics, general medicine, and stroke medicine.
Right. Wow. Amazing. So, David, as you know, this podcast is aimed at educating patients. So we try to avoid medical terminology as far as possible so that it remains as accessible as possible to everyone. So let's start with the basics. What exactly is a stroke?
Thanks, Gail, for reminding me. And I hope all your listeners, I use language that is appropriate and they understand. So stroke, in really principal terms, is a lack of oxygen to brain cells And as a result of that, the brain cells become starved of oxygen, and therefore they stop working. And as a result of that, the actions that those brain cells were normally undertaking when they were being supplied with oxygen through the bloodstream, patients start to develop symptoms. And what symptoms they develop depends on which part of the brain is involved. There are two main types of stroke. So one is when a vessel bursts and the blood leaks, and therefore it doesn't get to the target group of brain cells. And the other is when the blood vessel, the artery that's supplying the brain, blocks, and therefore the group of cells the artery was supplying doesn't get enough blood, therefore oxygen. As a result, those cells become impaired. The most common type is the latter type, the ischemic stroke, and that's 85% of patients will have a blockage of an artery, and that will either be a tiny little artery deep within the brain, or it will be a more proximal artery which is supplying a larger volume of the brain.
Okay. That's interesting. Okay. And you mentioned that this can cause symptoms. Can you I'm sure the symptoms must be myriad, but can you outline what symptoms patients may have that may make them think that perhaps, yes, I am having a stroke?
So thanks, Gail. The brain is fascinating and it's very, very complex. And so if we think of all the many thousands of small arteries that are deep within the brain, there are a multitude of different symptoms that patients can present with.
Yeah.
And I think the most important thing is it's the sudden lack of ability to do something that you normally could outside of obvious problems with the limbs or the eyes. So this is something that comes on suddenly, and you suddenly can't do something that you normally were able to. So we often help patients and talk about the most common being face, so abnormalities with regards to facial ability to smile and to raise one's eyebrows. We often talk about speech and whether or not there's a problem with either finding the right words, with understanding what someone's saying to you, or actually forming the words and slurring instead. So if there's a sudden deterioration or lack of ability to understand, find the words, or actually articulate them, that could be a sign of a stroke. And then also it's problems with limbs. And most often it tends to be one-sided, either the left or the right. Occasionally it can be both sides, but more often than not, it's one-sided. So whether they are unable to move their arm or their leg, and it's sudden in onset, and it tends to be persistent. So this isn't transient. This isn't for 10 seconds. This is something people could stop being able to do, and it remains. So there also can be problems with balance, vision, hearing, but they're less common. And we talk about this FAST acronym of face, arm, and speech. Now, you don't need all three, and that's the important thing. It can be just one modality, one part of your ability to do something that suddenly changes. And more often than not, it's without pain. So less than 1 in 5 people who have a stroke will have pain with it. And so it's the painless loss of ability to suddenly do something, outside of banging your leg or, cutting yourself.
And when you think of a stroke, at least when I think of a stroke, I think of something that is kind of catastrophic, really. Can you have like a smaller loss of ability that might signal that you're having a smaller event? So it's, should people ignore if you have a sudden change in your vision or something like that? Do you say, well, it's probably nothing, I'll sleep it off, or it's unlikely to be a stroke because in my head a stroke is a big massive thing? So is it possible to have a small change in function, a relatively small change in function, and it still be a stroke?
Thanks, Gail. So this is a really important point. So everybody's different, and dependent on which artery or on which part of the brain, their symptoms will vary. And it can certainly be a very minor change that is still a patient suffering a stroke. Now, of course, we know that those patients with larger volumes of brain that have been damaged tend to have clearly obvious abnormalities and problems with either speaking or walking or moving their arm, but it can be very subtle. And the important thing is to not ignore it. And if you suddenly can't do something that you normally could, you notice, for example, that you can't use your keys, you can't put on makeup, you can't do your shoelaces, put on your watch, and you think, my wrist's not painful, it's nothing to do with my hands, I just can't move it properly, or I just can't see properly, or my speech, I'm slurring. And it might be subtle. We ask patients, do not ignore that, and that, whichever country you're in, and in England, that is either 111 or 999 to talk through, and if you are able to speak, talk through with the call handler to get emergency help. We know that patients that do have minor strokes, although their chances of a really good recovery are high, they are at risk of another one or things getting worse. So it's really important that we don't, we're not too stoical and say, oh, you know, I'll sit down, I'll go to bed, I'll go outside to get some fresh air. The answer is no. Call for help and let healthcare professionals assess and potentially treat you, because things could deteriorate into something more severe.
Okay. Thank you. Thank you for that clarity, for that really clear definition of you can't do something you previously could have done and it's sudden. And for those examples, because that really wasn't what was going through my head. And I'm sure people will really benefit from that information, tying your shoelaces, putting on makeup. It would never occur to me. So thank you for that. So I always ask about risk factors for the conditions that I do interviews about, because there are some risk factors that it is difficult to modify. For example, genetic risk factors, you can't change your genes. But there are some factors that can be modified by lifestyle changes, for example. So are there any risk factors that you can talk us through that put people at higher risk of developing a stroke? And is there anything that people can do in turn to decrease their risk of getting a stroke?
Thanks, Gail. So of all the things we're going to discuss today, this is one of the most important. And stroke disease in general, about 4 out of 5 patients could have their stroke either delayed or prevented entirely if we had understood before they'd had their stroke what it was which was predisposing them to having a stroke. And so there's lots we can all do to ensure that we are in the best possible place to avoid or at least delay having a stroke. The reality is stroke is really common, unfortunately, Gail. And of course, it's the commonest cause of adult disability. And between 1 in 4 women and 1 in 5 men will have a stroke at some point in their life. So it's a really common condition. So what we want to do is give everyone the best advice to reduce the chances of having that in your middle and early later life. So there's lots we can do about it. And I think there are 5 key general vascular healthcare lifestyle advice that we give to everybody. The first thing is that we all need to look at our activity that we're doing each day. And we need to make sure that we are as active as we possibly can. Now, that doesn't mean running marathons or running 100 meters. It means walking regularly. And by that, I mean, not taking the lift, trying to have at least 4 or 5 episodes each week where we walk for at least 20 minutes and we're mildly short of breath. So that means you can still have a conversation on the phone with somebody, but they could tell that you were walking. So that's the kind of pace that we would ask everyone to try and get out and do that. Also, with regards to what we consume, so smoking is a definite no-no. So that's one of the most important reversible lifestyle choices that we would say to everybody, please try and not smoke. Now, what's important about smoking is it's not how much you smoke necessarily for vascular disease, so that's stroke or heart attack, it's the fact you smoke at all. So 3 puffs of a cigarette every 3 days is almost as bad as 30 cigarettes a day. Now, of course, that's not true for lung cancer or bronchitis. It's because within 3 puffs of a cigarette, all the sticky things in your blood, the platelets, they start to stick to the walls of the arteries. Now, the good news, though, is that these platelets, we get new ones every 3 days. Every 72 hours, the bone marrow pushes out new platelets. So it's really the abstinence of smoking entirely. So when I have patients who say to me, "Oh, Dr. Hargroves, I've managed to cut down. I've come down from 30 down to 5." That's wonderful and that's great. And it's good for your lungs. But when it comes to your vascular health of the vessels, you've helped it a tiny bit, but you're only going to get the real benefit from complete abstinence. So smoking is really, really important. The other thing, of course, is alcohol and recreational drug use. So again, there's association with patients that drink either binge drinking, and by that I mean high volumes of alcohol in one go, but also those patients that drink over 30 units of alcohol per week. So again, alcohol in moderation, possibly okay, and maybe even mildly protective, but anything over 21 units, we should all be thinking that probably is my limit, and certainly reducing binge drinking and recreational drug use. The other important things, of course, are weight. So again, we all need to, particularly in the Western world, monitor how much we're eating and what type of food we're eating. The various measures of whether or not we could do with losing some weight and having a different diet. So we've usually talked about the body mass index, where this is your weight divided by, so your weight in meters divided by the square of your height in meters. And so that's, we'd say that anything over 25, your BMI is overweight, and anything over 30 is we'd class as obese. And there's no doubt that once you get into the obese threshold, your risk of having a stroke rises significantly. So we should all try and get our BMI down. There's probably as an important weight measurement here, and this is the waist to hip ratio. So, of course, the visceral fat that one stores, particularly around the abdomen, is also a marker of the visceral fat that we're storing in our arteries. And so, in basic terms, you need to have a tummy that is slightly smaller than your hips. And if we find that, in fact, your waist to hip ratio means that it's not less than 0.85 for a woman and 0.9 for a man, you're probably storing more visceral fat than you should do. So as well as thinking about just your kilograms and your weight, it's also important to think about that waist to hip ratio. And you can do that with a simple tape measure around the umbilicus, just above the umbilicus, and they're the widest part of your hips. And jot that down and divide it. There's lots of calculators that you can get on most internet platforms that will do that for you, but we'd advise patients to just at intervals just check your waist to hip ratio. So smoking, alcohol, recreational drug use, exercise, and your diet and your weight are all really, really important. Behavioural modifications, and when it comes to the diet, of course, there's so much written about the diet. In general terms, we all need to have probably a more plant-based diet. We need to avoid excessive amounts of red meat. We need to think about more legumes and pulses. We need to avoid, as much as possible, refined carbohydrates. So what do I mean by that? Processed bread, snacks, cakes, sugar. That doesn't mean to say that you have to avoid them entirely, but we need to just be conscious that following a Mediterranean diet is probably one of the best methods of ensuring that what we intake is the best thing for our vascular system.
Yeah. And I could probably have transposed that brilliant and excellent answer to most of, if not all, my other podcasts, because the advice is always the same. So not only will that advice protect people from having a stroke or decrease their chances, it will decrease their chances of having so many other illnesses, so many types of cancers, loads of other illnesses. So absolutely important advice, and we can't hear it enough. Thank you for that.
So they're the reversible parts of the things that we can all do with regards to looking after ourselves. There are some things, as you rightly say, that we develop, not necessarily because of behaviours we've adopted, but we just develop. So hypertension, this is high blood pressure. So there's no doubt that having a healthy lifestyle, not smoking, not drinking, not taking recreational drugs, all of these are likely to reduce the chance of you getting high blood pressure. However, there are a group of patients that will get high blood pressure whatever. And it's important to make the acknowledgement that high blood pressure is directly correlated with your risk of having a stroke. And of all the conditions that high blood pressure leads to, and that is stroke and heart attack and peripheral vascular disease, aneurysms forming, for stroke, treating the high blood pressure either through the behavioural changes to your life or taking tablets has the most benefit. So it's really important that the 4 million people in England that have undiagnosed hypertension, and remember, the symptoms of hypertension usually are zero. You don't have any symptoms. You don't know you've got it. And so it's really important that everybody knows their numbers. And I mean that, and I sort of say to my children, do you know what your blood pressure is? And they look at me and say, Dad, I'm far too young for that. And I'm like, no, everyone should know their numbers. And certainly when you get to 40, you really should know what your numbers are. So that's the top number, systolic. The bottom numbers are diastolic. And I mean, the key thing I would say to everyone is that once you get above 120 millimeters of mercury, your blood pressure is on the rise. Now, that doesn't mean that you need lots of tablets when it's over 120, but it's rising. And that's the time that you need to be thinking about what can I do to keep my blood pressure as low as possible. And certainly when it comes to preventing strokes, we do think about that cut of 130 millimeters of mercury systolic, certainly for secondary prevention, and this is after people have had one event. We really need to ensure everyone's blood pressure is as low as we can get it below that. So blood pressure is really, really important. The other three things I just wanted to mention, if I may, is an irregular heartbeat called atrial fibrillation. So this is the most common arrhythmia, and by that I mean electrical abnormality of the heart. About half the patients who've got this won't know they've got it. The other half probably do get a few palpitations. Some patients can get a bit short of breath, but the majority of people won't really know they've got it. And the irregular heartbeat gives rise to clots forming in a little chamber within the heart, the left atrial appendage. And these clots one doesn't know they've got. But of course, the body is constantly breaking down clots within the body. Constantly. We're forming clots on all our arteries and within our heart all the time. But we've got these natural clot-busting enzymes in our bloodstream, the fibrinolytic enzymes that are running around breaking down these clots all the time. And we have this steady state of hemostasis, we call it, where clots build up and they get broken down. That's normal. What happens with atrial fibrillation is the clot building mechanism, because the heart's doing that as opposed to nice and synchronously beating, more clots build up than the body can break down. And as a result, some of those clots can break off, and some of them are tiny and don't cause any damage. Others are a little bit larger and fly off and go up to the brain in the majority of cases. And those people who suffer those type of strokes, they tend to be a bit more severe, more disabling. So atrial fibrillation, again, if you've got an irregular heartbeat, you feel your pulse or you feel someone else's and it's irregular, tap it out. You need to be contacting healthcare services. Maybe not that second, but within the next few days, if you find an irregular heartbeat, you should be contacting your local healthcare provider, whether that be your GP or 111. You don't need to come to hospital immediately with an irregular pulse, not at all. But in the next couple of weeks, someone should have done a tracing of your heart, an ECG, and potentially had a discussion with you about what the benefits are of treatment for that irregular heartbeat. The third really important condition that gives rise to strokes is increase in cholesterol, so lipids. And we know that this is a genetic propensity, so people are just born, unfortunately, with an ability to either break down the cholesterol that we absorb from our gut or less of an ability. So yes, diet is important, but often it's about how you were born and your genes. And so knowing what your lipid profile is, and particularly once you get over 40, what is my cholesterol? And the key number really is and there's lots of different measures of cholesterol, and total cholesterol is important, but the one particularly for stroke and heart attacks, we like to think of this as brain and heart vascular health, is the non-high density lipoprotein, the non-HDL level. And this can be calculated through a non-fasting sample. We really do like that to be less than 2.5 or 2.6. And that's kind of the figure that if people were going to take away and say, what's my cholesterol? I would say, ask your healthcare provider, what's your non-fasting, non-HDL cholesterol level? And the key figure is less than 2.5 or 2.6. And if not, then there are discussions to be had based on your other risk factors, about whether or not there are dietary modifications or tablets that you need to take. And then finally, Gail, and I'm sorry that we're talking about this in great detail, there's also diabetes. So diabetes is a condition, again, that type 2 diabetes that tends to affect slightly middle-aged and older people. It's genetic in about 90% of patients. And it's really important that we help everybody to reduce their chance of getting type 2 diabetes, and that's particularly relevant with regards to individuals' weight and exercise. Type 1 diabetes, there's less we can do about avoiding that. That tends to just happen, and again, has a genetic link. But both types of diabetes are associated with difficulties within the arteries, whether that be stroke or the heart or the peripheral vessels or the arteries at the back of the eye as well. So understanding that people who are diabetic or at risk of developing diabetes in the pre-diabetic stage, really important that they are helped to do the best they can for their general vascular health to reduce these multiple factors that can conspire to lead somebody to suffer a stroke.
Okay. And if you are listening to this podcast and are diabetic, then you can listen to my podcast on diabetes, where you'll get far more detailed information as well, which is really helpful. Okay, so that explanation was fantastic. And it takes me nicely to my next question, which is there any way of screening people for an increased risk of stroke? So I guess blood pressure would be one of them. Is there a screening program? I mean, in gynaecology, of course, we have the cervical smear program that so we're very keen on screening. Is there anything similar, a screening program, or is that something that patients can? You mentioned know your numbers. Is it that kind of approach? There's not a formal program, but people can do something to assess whether they may be at higher risk.
Thanks, Gail. So it's really important for us to just accept, unfortunately, there isn't a magic blood test. There isn't a magic scan that could predict at the moment who is more likely to have a stroke and who isn't. What we do know is those reversible risk factors that I've spoken about regarding lifestyle are really important, but also this pulse and blood pressure and knowing what your lipids are the three things that we would suggest everyone, as they get into their later adolescence, 40, we really do need to be encouraging people to know your numbers. And that's the most important factor. Now, we also know that if a first-degree relative has a stroke less than 65 years of age and they weren't a smoker, that does mean that first-degree relatives are slightly at high risk of suffering from a stroke themselves. So, because unfortunately it is a common disease, it's likely in a family that someone will have had a stroke in later life. But if that individual was less than 65 and were a non-smoker, it does mean that other family members who are younger than them are more likely. Now, they don't need lots of fancy tests, but they do need to have their blood pressure done. They do need to have their pulse checked. And I would advise them to know exactly what your glucose level was to make sure you haven't got the early signs of pre-diabetes, and also their lipids. And that's, not for people in their teens, but once you get to 40 with a first degree relative less than 65 is a non-smoker, they're the people we really should be encouraging. Build up a relationship with your healthcare practitioner, with your GP. It usually will be a practice nurse that can offer you a vascular check. We know now that in England, as of the middle of March, you can get your blood pressure checked over 40 in a pharmacy. The pharmacist will do this for you, and it's a really important marker of reversible parts of stroke prevention.
Okay, thank you. So I think that information is really useful. And for ease of accessing that information, I'm going to put those parameters that people should be aware of in the notes for the podcast so that it's easily accessible to them. Okay, so my next question is, how is a stroke diagnosed? What investigations are performed and what can patients expect? So maybe, as you have outlined before, I wake up one morning and I feel I have some weakness in my arm, or I can't do something that I normally do. And I think it occurs to me, maybe I'm having a stroke. What would you advise that I should do? Where should I go? And what investigations can I expect to be performed? Because I think that sometimes a barrier to people to accessing care is not knowing what to expect and being worried about what they can expect. So can you please outline to us what is likely to happen next when you do ring 111 or 999 or whoever you ring? What can patients expect?
Okay, thanks, Gail. So this is a really important question, and it can be really frightening for patients when they suddenly develop the inability to do something. So the first thing I would say to people is try not to worry. There are 107 stroke units in this country that are open 24 hours a day that are waiting and able to look after patients. So if you suddenly cannot do something doesn't work, and it's really important that this is outside trauma. This is outside, banging yourself on a door or, falling over. This is sitting there, or you're driving or sitting at the dinner table watching TV. You suddenly notice, or when you wake up, I can't do something. Something doesn't work. Something's not normal. I would pause. Yeah. I would give it a few minutes because it may well be transient. I would wait, but then I would be calling for help. So by that I mean, is there someone in your house? Is there someone nearby? Ask somebody for help. If you're on your own, I would wait a few minutes, and if it's still there, as in you still can't do something, that is 999. Mm-hmm. And if you're with somebody, I would try and explain to them, or point if you can't speak. Point to them what's not working. And we ask people, the bystander, let's think of them as stroke savers. We'd ask them to undertake the FAST test. So that's, looking at them. Can they smile? Can they show them their teeth? Can they lift their arms up? And it's only one arm that we're looking to not be equal. And what is their speech like? Yeah. And if any one of those three is abnormal, then it's 999 and call for emergency assistance. Now, of course, there are other symptoms and other inabilities to do things that could also mean a stroke. So that's, can't walk properly. I can lift my arms up, I can speak, my face is fine, but suddenly I have an inability to walk properly. I'm unsteady, I feel giddy. Again, most likely these aren't symptoms of a stroke. And that's the other thing that I would say to patients is over half of all patients that come to NHS hospitals with someone thinking they might have had a stroke, whether that's a patient or another healthcare practitioner, fortunately turn out to not have had a stroke. So even if you develop these symptoms, it may not be a stroke, but we'd like to see you, and you really do need to see an experienced specialist stroke clinician. So in England, most of those are either doctors or nurses that have had specific training in the recognition of stroke symptoms. Our paramedic and ambulance teams have also had specific training to spot the symptoms, what the patient complains of, and also signs of a stroke. And they will communicate with each other once you call for help to work out what the best treatment for you is. But just to reassure you, half of people with the developing symptoms that someone thinks is actually turn out not to have had a stroke. But don't fear about wasting anyone's time. We really, really want to hear from you. And that is 999 or 111. And explain the symptoms, or the bystander, explain your symptoms to the call handler, who will then guide you as to what the best course of action is. And for a group of patients, that is an ambulance being sent to your home or wherever you're found.
Okay. And if someone does have these symptoms, how quickly, I mean, I think I know the answer to this, but how quickly should they access care? You've mentioned it. What are if they don't access care, does that make the outcomes worse?
So thanks, Gail. So we have these stroke units, and we have our paramedics that are here 24 hours a day to help make that diagnosis. There's no doubt the earlier a patient who is suffering from a stroke gets treatment, the better. And that's because when one is suffering a stroke, we lose almost 2 million brain cells every minute. And so if you are really concerned that you or someone you see or are with can't do something, and it's sudden and it's persistent, then that is get help straight away. And so what will happen is the emergency. So what will happen is the call handler will receive the call, will go through some questions with either you or whoever's phoning. And as a result of some of the questions they ask, they will order a blue light ambulance or potentially sometimes a paramedic to go out and see the patient and make further assessments. We've now got a project going in England called pre-hospital video triage, where about a third of the country has a system where the paramedics and ambulance teams communicate with stroke specialists in a hospital, and the stroke specialist can see the patient at home or wherever they have been found, and have that two-way conversation regarding what the likely diagnosis might be and whether that patient does need to come straight to hospital. If the symptoms are very consistent with a stroke, then they will be sent by blue light ambulance to their local, and we call it a hyperacute stroke unit, and that's where a unit that open 24 hours a day with a whole range of skilled clinicians who are ready to care for that patient. Once they get to hospital, one of the important factors is to have a brain scan. Stroke is a clinical diagnosis, and by that I mean it involves a complex examination, but we do need a brain scan of some sort in most patients to ascertain not only what part of the brain is involved, but also whether it is the type where the vessels burst and there's bleeding, or whether in fact it's the type where the vessel blocked, and we call that an ischemic stroke. So getting to hospital quickly by ambulance, having a brain scan very quickly, and by that I mean we hope most patients get their scan within an hour. We hope that there'll be a group of patients that have their scans sooner than that, particularly if we're thinking that a vessel has burst or a vessel is blocked and we need to use some treatment to try and unblock the vessel.
Okay, yeah. So that seems pretty straightforward, and nothing that, nothing that's painful, for example, no reason to not go along, because it will be a clinical examination, it will be a scan, I guess maybe some blood tests, because we always do blood
So,
tests, don't we?
so Gail,
Um,
I think it's really important for you to mention that. So, I would urge everybody. Hopefully, you're going to be met by a really wonderful group of healthcare practitioners that are waiting to
yeah,
look after you. And yes, there may well be a needle in the back of your hand or in your arm to take some blood. And sometimes we need to give a bolus of contrast to look at the brain in more detail. But
hmm,
there's certainly no painful
yeah,
examinations. We won't be doing anything to hurt. And we'll be there to listen and to examine and to take care of you. And we are here to help. That's the important message.
great, wonderful. And okay, so let's take the story along. So you've had your symptoms, you've done the right thing, you've called for help, and your partner, whoever is at home, rings 999. You go in, you end up in one of these stroke units. You are examined. You have a scan, and a stroke is diagnosed. What happens next? What are the treatment options?
Thanks, Gail. So it's probably best to separate this into two main types. So we know there are two types of stroke, when the vessel
Yeah.
bursts or the vessel clogs. So if the vessel bursts, we call that a haemorrhagic stroke or a bleed within the brain.
Mhm.
What's important
Yeah.
is because that bleeding stops within seconds because of the pressure within the skull. That bleeding tends to stop within seconds. So once the vessel bursts, uh, literally for a number of seconds, there's some bleeding, and then it stops itself, usually. What we need to do is to stop the chances of any more rebleeding, and that's where blood pressure control is really, really important. If people are on blood thinners, and by that I mean warfarin or some of the more novel or direct or anticoagulants, the DOACs, things like Pixaban, dabigatran, edoxaban, rivoxaban. If you're taking one of those and you have a bleed, then we try and reverse the effects of those drugs. And we also know that there are a small group of patients where the type of bleeding and where it is within the brain, the bleeding has stopped, but swelling occurs around that part of the brain that's been damaged. And that swelling itself can cause problems. And there are a small group of patients, maybe 5 to 10%, that actually do need an operation to try and remove the part of the brain where the clot is, to allow some of the swelling to have space to swell. So there's a small group that do actually need some neurosurgery. The vast majority, though, of patients with we call it an intracerebral hemorrhage, what they need is a rapid scan, blood pressure reduction if they have got high blood pressure, and anticoagulant reversal. And they're the sort of things that will happen for patients that have an intracerebral hemorrhage. The other group, the patients that have a blockage of an artery, there are two main treatments for that. One is where we unblock the artery with medicines, intravenous medicines, and we call these fibrinolytics. Remember, we've already got them in our body already, but we
Mhm.
don't have them in the concentrations to break down the big clot that's formed in the brain. And we call this a thrombolysis, and we give it via injection. The other type of treatment is where we put a wire, usually from the groin, sometimes from the arm, up into the brain, a bit like we do for heart attack. Patients who are suffering a heart attack, we put it up into the brain and we are able to remove the clot directly. That's something called mechanical thrombectomy. So between 20 and 10% of all patients are likely to benefit from either thrombolysis, clot-busting treatment, or the wire treatment. And so that's not everyone. So 4 out of 5 patients are not going to benefit from this treatment. One question that patients often ask me is, why can't everyone have this treatment? Why isn't it appropriate for everyone that's got a clot within the brain? And the answer
Mhm.
to that is that both the clot busting medicine and the wire treatment have their risks. And we need to make sure that the artery that's blocked is amenable, i.e., you can get to it. It's not in such a tiny vessel that the
Mhm.
wire going in would cause a puncture. And we also need to appreciate
Yeah.
that giving the clot busting medicine can be dangerous to some patients if they already have bleeding tendencies. There are also a group of patients that, because our brains are set up differently and they're supplied differently, sometimes the area of brain that's been damaged, it doesn't matter about opening the pipe. Unfortunately, that damage is already there. And actually, by opening the vessel, either through the wire or the clot-busting medicine, and we call it reperfusing, allowing blood to go back round the damaged part of the brain, can in itself cause more problems. So it's quite a detailed individual patient selection about who will benefit. And that's why we don't do it in every GP practice or every hospital in this country. We do it in designated hyperacute, acute and comprehensive stroke centres, of which there are 107 in England.
And I guess that explains the importance of having the scan before treatment, because you don't want to give the clot-busting treatment to someone who's bleeding already into their brain. So that might explain to patients, or why didn't they treat me right away? Why did I have to have the scan? Because they're two diametrically opposed types of stroke, I guess, and the treatment is really different.
Completely, exactly. And that's why it's vitally important that patients have access to a brain scan really quickly and within that golden hour.
Yes, absolutely. Okay. And can you give us an idea about how successful treatment can be and what factors might influence success in treatment?
Yes, thanks, Gail. So there's no doubt that in the throes of a stroke, the earlier treatment is started, the trend is for a better outcome. And we know that there is quite a sharp reduction over a number of hours in benefit. And so we really would like to start treatment on patients within 3 hours of them having symptoms. So that gives people a little bit of a time marker in their mind regarding when the symptoms start and when they actually get to hospital and get their treatment. And then once we can still treat people up to 4.5 hours after their symptoms, we can treat people up to 6 hours. And there are some people that we can even treat 24 hours after their symptom onset with these clot-busting drugs or the mechanical thrombectomy, but the benefit tends to be less. And what I would probably say to patients is that with the clot-busting treatment, if we're able to give you the medicine within 3 hours of the start of your symptoms, 1 in 10 patients has a really, really good benefit, really positive benefit. With the wire treatment, mechanical thrombectomy, if we can actually perform the procedure within 6 hours of symptom onset, 1 in 3 patients has a significant benefit with regards to reduction in their disability. Once we get a little bit longer than that, and for the clot-busting medicine, up to 4.5 hours, it's probably 1 in 20 patients that gets the benefit as opposed to 1 in 10. So we get half the benefit. So speed really is of the essence, which is why we would say to all patients, don't sit at home for an hour hoping it's all going to go. Call for help and let us help you.
Yeah, absolutely. Okay. And what are you alluded to this before, what are the risks or side effects of treatment that you think are worthy of mention today? But of course, what you're treating is such a potentially catastrophic thing. I guess you'd allow for greater risks and side effects. But people need to know, what are the possibilities that can happen if they have, either the clot busting or the surgery or the wire treatment?
So if we take the latter first, mechanical thrombectomy. So we only tend to offer this type of treatment for those patients that have a large artery within the brain blocked. So they are going to be most likely suffering with significant symptoms. So that's an inability to really be independent. So inability to walk or speak or move an arm, and that vessel really does need to be opened as soon as possible. Yes, there are complications associated with it, but serious complications are less than 1 in 50. So 49 out of 50 people that have a mechanical thrombectomy will not have a serious complication of that procedure. Their stroke may not, or the symptoms from their stroke may not improve significantly, but they won't have a significant complication, which is good news. With the clot-busting medicine,
Yep.
again, if used appropriately, the risk of bleeding as a result of the clot-busting medicine does exist, and it's about 1 in 30 that will have some bleeding. Not all of it is serious. Not all of it is significantly disabling to the patient, but it is about 1 in 30. What we would say to patients is the benefit from the clot-busting drug compared with not having it is about 10 times. So the risk-benefit versus risk-harm, it's about 10 times in favour of having the treatment than not. And that's within, organised, appropriately trained staff. But there is a small risk. You're right, Gail, but it's about 3%.
Okay. Surgery?
Well, so again, if a patient is offered surgery, and that's because either there's a pressure build up within the brain and they need to have that pressure relieved. So developing hydrocephalus is what it's called when there's pressure build up, or if there is a blood clot, a bleed that is being removed. We only offer that within the NHS when we are reasonably confident that the benefit outweighs the risk. But you're right, every operation has its risks of another stroke, of bleeding complications, of infection. And we do save neurosurgery for those patients who have the most to gain from that intervention.
Yeah. And it's all a discussion, isn't it, between the patient and the clinicians? Okay. And what about the longer term management of patients who've had a stroke? What does that look like? I guess it depends on where was affected, how well they recovered, etc. But can you give us an idea of what people can expect again?
Yes, you're right, Gail. So what we would say to start with is that the recovery from a stroke goes on for many, many years and probably lifelong. There will be a group of patients that do recover and don't look back, but the recovery journey is a long time. And secondary prevention is based on that individual. There are some common themes, though, as are the original risk factors. So high blood pressure. So, it's likely that there may be an element of high blood pressure that's going to be needed to be managed lifelong, probably with tablets, and most definitely with some encouragement regarding lifestyle modification. So all of those factors I mentioned to start with regarding alcohol, smoking, exercise, diet, and weight gain. There is also, depending on the type of stroke, a benefit if it's a blockage of an artery for antiplatelet medicines. So such medicines are like aspirin or clopidogrel, or combination of both. It's likely that patients are going to be on an antiplatelet if what the problem was a blockage of an artery for the rest of their life. It's likely that there will be a combination to start with for the first 3 weeks, and then the patient may just have one agent. And then also lipids. So we know that reducing that non-HDL, non-fasting cholesterol level is really important, both in primary but also secondary prevention, which is after an event. And so it's highly likely that a patient with an ischemic stroke is going to be put on a form of cholesterol lowering, and the most likely is a statin, and a higher dose statin. And if patients can't take a statin for whatever reason, and about 5 to 7% of patients can't, there are other medicines that they could use. The key about the lipids and the management of lipids is that not just that patients get a tablet, but they get their cholesterol checked about 6 to 8 weeks after they've started the medicine. And this can be done through their local GPs. Yeah. And what's important is, as well as the absolute level, remember that 2.5 figure, it's also the reduction that we see, and that you have medication added to that initial dose if you're not reaching the target of a non-HDL, non-fasting cholesterol of less than 2.5.
Okay, great. Okay, so other long-term management strategies, apart from what you've said, I guess things like physiotherapy is necessary. Are there? How does that work?
So again, there will be a whole multitude and variety of symptoms that patients present with and needs that they have. And what we'd like to suggest within stroke care, that it really is a multidisciplinary team assessment and also treatment plan with the patient and their family or friends or their loved ones or caregivers. And every patient will have individual needs, and whether that be psychological, whether that be fatigue, and it's really important to note that these are the hidden symptoms that patients can have from a stroke. So they might get back their recovery in their arm or their speech, but half of patients may suffer with a mood disturbance. So whether that be low mood, depression, anxiety, or a change in personality. They may also suffer with fatigue, and this is one of those really hidden, difficult problems that patients often note, and that's this excessive fatigue. And by that I mean not just sleepiness, but the lack of energy to do things. And that is a really common symptom, and it's a holistic approach. And I think the first thing I would say to patients is speak up and describe those symptoms. There are lots of healthcare workers that are keen to help and to listen. And most importantly, be kind to yourself. It's okay to take a nap in the afternoon. It's okay to go to bed early. It's okay to then get up later. There aren't any hard and fast rules about what you should or you shouldn't do, but listen to your body and talk to people about this. We have a great third sector, and by that I mean charity sector in England and the United Kingdom. We have a number of charities that are really geared up and for patients with regards to support groups, but also information to allow them to have an avenue to have this collaborative approach to improving life after stroke. So, I mean, the three main charities in England are the Stroke Association, Different Strokes, and also Headway are three big charities that are there to help patients. And again, if there are individuals watching this that have not made contact with their local stroke charity, I would recommend that you get involved, because there are other stroke survivors who are thriving now. And yes, life is different, but they've been through some of the real, on occasions, dark moments, but they are now being able to acknowledge that things might be different, but there is great joy to be had, and there is a life that they are keen to share with others and help you through some really difficult times, which I know many patients describe.
Thank you. And I will put links to those three charities in the notes of the podcast again, so that people can find them easily. Okay, so thank you for those clear and detailed answers to my questions. As you know, beforehand, I invite listeners to submit questions that I ask the expert on their behalf. Are you happy for me to ask you some questions or some themes that have been submitted?
Yes, let's talk about some of the themes that some of your watchers and viewers are keen to ask.
Okay, so I must stress at this point that it is very difficult to give specific and personalised advice to patients without a thorough knowledge of their past and current medical history, examination findings, and investigation results. Also, due to time constraints, I have summarised the questions in a way that I think retains the essence of what is being asked. Therefore, these answers should only be used as a guide, and individualised care and management should be sought from one's own doctor. Okay, so because we've had so many questions for you, David, I have tried to group the questions in themes. And I think with these themes, I will cover, and you will cover, more importantly, the answers that people want out of you today. So the first theme is I've had a few questions asking about recurrence. And I will read them. I would like to know the probability of having a second or third stroke having had one already. I'll read them all, David, and then you can kind of summarize if that's okay with you. Does the chance of stroke recurrence decrease with time? third question is, with the right meds and lifestyle changes, how much will those meds avoid a further recurrence or anything worse? And lastly, my question is, what is the post-stroke prevention medication protocol for prevention of another stroke? So basically, risk factors for having another stroke, you've touched on that already. What is the probability of having a second or third stroke? And do the medications and lifestyle changes affect the likelihood of another stroke? Can you speak a bit
Yes.
about recurrence?
So thanks, Gail. So this is
Again,
a frequent question that my
I'm
patients
sure, yeah.
ask regarding what is my risk of having another event, and we within the stroke fraternity really understand how worrying this must be, because of course most patients who have a stroke had no warning and it just happened. There's no doubt that after one stroke, patients are at risk of another. And the risk tends to be most significant in the first few days after the stroke. So the longer you go from your first stroke, the less the likelihood of having a recurrence. So it's front loaded, and that's one of the reasons why we say to patients who've had a transient ischemic attack, a TIA, which is where the symptoms resolve, don't drive for 30 days, because the risk is greatest in the first 30 days of a recurrence or a full-blown stroke. Now, all the data that we have on recurrence rates are predicated about when the study was undertaken and whether or not we had lots of the modern medicines we've got now. And so certainly the cohort studies that look at following people through, because the interventions that we can do now, the modern secondary prevention, we call it, the blood pressure lowering, the antiplatelets, the lipids, the lifestyle changes, it's difficult to really determine how much benefit they add, but they probably reduce your risk by half. And if you added in lots of the lifestyle advice that we give, you might even be able to reduce your risk by more than a half and almost 2/3. At 5 years, some of the data without that intervention would suggest that 1 in 6 patients has a recurrence. And if we flip that round another way, 5 out of 6 don't. And if you have treatment, the secondary prevention, and you have the lifestyle interventions, you might be looking at 9 out of 10 patients not having a recurrent event. Now that, many of us would say they're not bad odds actually, but that does involve modern medicine. It involves taking your tablets. It involves ensuring that when you run out, you get some more before you've run out. It involves some of those lifestyle interventions. But yes, there is an increased risk once you've had one stroke, but you can reduce that possibly down to 9 out of 10 patients having an event at 5 years.
Okay, 9 out of 10 not having an event at 5 years.
Yes,
yeah
9 out of 10 not having an event
the
at
next
5
question,
years.
not having an event. So the next question is around diet. What would be the potential for greatly reducing the risk of stroke and metabolic syndrome if we could ever make a concerted effort in returning to eating whole, real food, prebiotic, and get rid of vastly reduced refined sugar and highly processed foods, and in reducing longer-term stress in everyday life? I look at it this way: you can't fix people until you fix healthcare. You can't fix healthcare until you fix a diet. This said, there will always be a place for medical professionals, but I'm a firm believer in prevention being better than cure. So that, I think, nicely summarizes a lot of what you said, actually. The other question is there a link between stroke and the gut microbiome? Gut health seems to be responsible for so much these days. Have a good interview.
So again, there's no doubt that diet is really important, and we're learning so much about the gut microbiome. I am sure that in the future there will be some specific evidence as to the benefits of this wholer food, Mediterranean based diet. And
Yeah.
Coming back to this earlier discussion that we had about reduction in refined carbohydrates, less saturated fat, more legumes, pulses, fish, plant-based food. This is something that we should all be having more of in our lives in the Western world,
Yeah.
where unfortunately the availability of highly refined foods, unfortunately, it is very prominent. So we would all benefit, not just with our reduction in stroke care, but in our general, and you mentioned it earlier, neoplasia risk factors, cancer risk factors. So having a more plant-based diet is of good news when it comes to prevention of all vascular disease.
Okay. The next group of questions is interesting because I didn't expect this, and this is the beauty of asking people to submit questions, because there's no way I could come up with these questions, because it's not, these people are living the issues. It's about young people having strokes, and about migraines. So why isn't there more awareness of younger people having a stroke or TIA? And a TIA is a transient ischemic attack. You've mentioned them before, both publicly and with medical staff. So many stories of young people being told it's a migraine and then later finding out it's been a TIA. The next one is, why does stroke get misdiagnosed as migraine seizure? Isn't there something different that can define a stroke from a migraine seizure, no matter how small, as the difference could be life-changing? And I mean, people get the correct help, as every second counts if it's a stroke, as you said before. Third questions. I get migraines, and I sometimes worry that one day I'll have a stroke. Am I in a risk group because of migraines? Next question. Why are young women routinely having strokes misdiagnosed without being investigated by MRI or CT? So often they're sent away and told it's migraine. So can you talk a little bit around migraine, the differentiation between migraine and stroke? Does migraine put you at increased risk of stroke? Because that's a really interesting aspect.
So thanks, Gail. Yes, there's no doubt that diagnosing a stroke in patients that have subtle symptoms can be difficult. Migraine in itself, of course, there's a whole spectrum of symptoms that occur with migraine, and whether that's with or without pain, with or without aura, and by aura I mean sensory disturbance, whether that's visual, whether that is abnormalities with their sense of touch or light, or whether it can actually affect their speech. These variants of migraine can be very similar to patients actually having a stroke. We do know that most patients who have migraine, and it's very common migraine, I know 15% of men, almost 1 in 5 women have some form of headache syndrome, so it's a very common condition. Most of those patients are never going to have a stroke. That's the important thing to say. There is a slightly increased risk if you have a migraine diagnosis, almost a doubling of your risk of having a stroke in the future. But remember, most events are not going to be a stroke. So it is difficult, though, Gail, sometimes to decipher between what is my migraine and what is actually stroke-like symptoms, because sometimes they can be very similar. And the advice I would give to patients that are who's suffering with migraine, if there's a sudden change in the way you experience your migraine symptoms, whether that's with or without headache, and it involves a deficit, a lack of ability to do something, and for migraine sufferers, it lasts more than 20 minutes, then you should call 999. So by that I mean, if you're a migraine sufferer and you normally get flashing lights, falsification spectrum we call it, and suddenly you can't see out of your eye. It's black. You can't see anything at all, and that stays there. It doesn't get better within a couple of seconds. It's sudden, and it stays there. Even if you're getting a headache or your normal headache as well, you suddenly can't see. That's 999. It's the same if you can't move your arm. You suddenly can't speak, and that's not normal for you. So I think with people who have headache syndromes, it's the sudden change and not positive things, flashing lights, pins and needles. It's I can't do something. I would wait a short period of time, but for them, it's 999 as well, because we'd like to see you. And all of these patients, we should be examining carefully. And there will be a group that do need a scan. And again, I would say to patients, if you're really worried and you're calling 999 and you think that whoever you're speaking to is not taking you seriously and that your symptoms are different, and I think that's the key to say, this is not normal for me. I'm different,
Yes.
and what I'm experiencing today, I never get. That's really where the alarm bell should be. And I would like to think that most healthcare practitioners who hear that would say, yeah, let's really investigate you. Of course, there's always a balance scale, because we don't want, people in and out of hospital, and, many patients with migraine.
Yes.
And they have clear parameters where we agree, when will you come back? Because you're going to, unfortunately, migraine is a chronic condition and people have recurrent events, and sometimes they can be daily. We don't want people being overly worried, but people get into a pattern usually with their migraine. And it's when it suddenly changes that we potentially need to see you and to examine you and take a thorough history. And some of those patients will need a scan. And you're right, Gail, more often than not, an MRI scan is helpful for those patients that might be having another disease that isn't stroke, just to look in the brain in a bit more detail.
Yeah. And I'll take this opportunity to inject some gynecology into the discussion, to say that women who have migraine with aura, as you've described, are not candidates for the combined pill, because it puts them at unacceptable risk of stroke. So I'll just pop that in there. Okay. So the next
Gail, before we go on, because this is really important, I agree with you entirely. So, the estrogen element for the oral contraceptive pill, we do know there is an association, and certainly it may be that your healthcare team, if you were to suffer what was diagnosed as a TIA or migraine with aura, you will be asked not to have estrogen, and that's the same with HRT as well.
Absolutely.
And so, we do know that
Absolutely.
the estrogen does affect your vasculature and increase your risk slightly.
Yeah, thank you. Yeah, absolutely. Okay, so next questions are about follow-up. I had a TIA 2 years ago and have not seen a doctor at all. Is this common practice? Why does it take so long for follow-up post-hospital? 6 months since mum has left and no follow-up with a specialist. No pathway start from her GP, and all they can do is refer. So there doesn't seem to be a focused one point of contact approach or ownership of care. So maybe you can direct that. Why can't the NHS fund a stroke physio after the first year? I can't afford to pay a private stroke physio anymore, and I still want improvements. And then the last question, too many doctors still believe that you only have 6 months to recover. And I know many survivors who were told they will never do whatever it is, but this is a lie. And many go on to prove doctors wrong. Why do doctors still believe this? I'm 18 months post-stroke and still recovering, albeit slower now. Also, neurofatigue, there seems to be a belief that this recovers after 6 months to 1 year, whereas I know many people that suffer for many years. Better education, that's why we're here today, is needed to help survivors, especially young stroke survivors. So a bit about follow-up, a bit about, you touched on this before actually, recovery, maybe going on for many years after the stroke. Would you like to speak a bit more about it?
So thanks, Gail, and thanks for your listeners writing in with their questions. So the first thing I would say is I'm really saddened to hear that some individuals or their loved ones are struggling to get the care that they think they should have. We work really hard, and when I say we, I mean the royal we, for everyone involved in stroke care, to try and provide a patient-centred approach. So we should all be moving away from this idea that it's a fixed period of time that people get help. We really do need to be moving towards a patient-specific rehabilitation program that takes into account their needs and it should be when the patient needs it. Now, of course, there aren't limitless resources within the NHS. We know this, but we should be offering rehabilitation for as long as the patient is benefiting. And what I would suggest to patients is, if you feel that you are not getting the therapy or the review that you would like, the first port of contact is your GP surgery. The second port of contact is the hospital where you had your treatment for the stroke. There is also an avenue to contact your local third sector charity, who may well have a support offer for individuals that can help understand what their needs are and link in with the healthcare teams, the stroke specific teams. Most healthcare services really want to hear from you, and that's not to say that we can do everything for all patients, but what we certainly can do, I hope, is to listen and explain and understand and have a bespoke program for each individual patient. What's really important is this concept of experience dependent plasticity. And by what I mean by plasticity is the brain, the nervous system changing in response to recurrent stimuli. And rehabilitation is really geared up to repetitive experience, doing the same thing again and again and again, dependent plasticity. So the more you do within reason, the more benefit you're going to get. And the brain has an immense capacity to relearn activity that it's lost. And I would certainly agree with one of your listeners that there isn't a fixed time point that says at this stage you will have, reached X. Everybody is different, and that's why we need to work with you, with a whole multidisciplinary team, to work out what's best for you. The good news is the vast majority of the exercise dependent plasticity you can do at home. You can do with your family, with your friends. You can do some of this virtually. You can do it with regards to gaming technology. So it doesn't have to be a therapist or a suitably qualified individual one-on-one. Some of this can be done in groups. And, dare I say it, and of course we're all bad at undertaking our exercise, it can be done individually at home, regularly. I don't just mean once a week. I'm talking about 3, 4, 5 times a day, short bursts. So there's lots that can be done, and it does need to be an individualized program. And it's not doctors really that need to see everyone. So we have lots of specialist nurses and therapists that are skilled and equipped to provide patients with this eclectic, and by eclectic I mean this all-encompassing level of care. Because what most patients need is actually a bit more than 6 minutes in a GP practice, or 15 minutes with a consultant. They need a bit longer than that to really explore some of the hidden symptoms, some of the mood disturbances, fatigue, sexual dysfunction, relationship problems. All of these things are common after stroke, and you need time and space to discuss those things. And that's not always best undertaken with a doctor who's got X number of patients to get through within a short space of time. So lots of other healthcare practitioners who are available and keen to help patients.
That's great. So there's support available, and you've done the first thing. Thank you for reaching out to me. To reach out to your local healthcare providers or to those charities as well. There's help there. We just need to access it and to know how to access it. Okay, the next questions are about fatigue, which you brought up yourself actually and spoke a little bit about it, and I didn't realize that this was an issue. And knowing about this is so valuable for people to think it's not just them, it's not something that's wrong with them, it's common. And also for family members who live with the person to understand that this is all part and parcel of having had a stroke. So the questions are, why is fatigue after stroke not recognized as a debilitating effect? And what can be done about fatigue? Not one doctor has suggested anything. It seems to be a very common problem, but is simply ignored, and we're told to live with it.
So I mentioned fatigue quite early on. So this is probably the most common symptom that we describe sometimes as hidden to other people. It's not hidden to the stroke
Yeah.
survivor, and it's a really, really disabling symptom. And for those people who don't suffer, the only way I can describe, as patients describe it to me, is this absolute lack of energy to do things, whatever that may be, and that is really disabling. So it doesn't matter whether someone's regained their ability to walk or to speak or move their arms. If they have no energy to undertake it, regaining that function has much less value. So I think the number one thing here is, I'm sorry if individuals feel that you're not heard. You are heard, and we recognise it, and we should recognise it as a very common problem. Up to 50% of stroke survivors will suffer an element of fatigue. The second thing is, speak up, be heard, and be kind to yourself.
Yeah.
Because the number one thing to improve fatigue is to not have unrealistic expectations of yourself. So we see this in patients that want to go back to work. They want to go back to some of their caring duties. They want to go back to their vocation or their hobbies. And they feel that they can't go back to work because they can't tolerate a half day at work. And the failure to be able to return to what they were doing immediately creates an awful lot of anxiety for them. And so my number one thing to say to people is, be kind to yourself and don't rush. Take things in a stepwise approach and listen to your body. Ensure that those around you understand that you will have good days and bad days, good weeks and bad weeks. And that doesn't mean anything other than your brain is getting used to the new norm. And it will take time to reset. The good news is that with appropriate individual listening to a patient and the patient being able to rationalize what their expectations are, the fatigue does appear to get less over time. So be kind to yourself. And, if you're expecting to run back to work and, work 8 hours, 12 hours a day, that may not happen. And that's not because there's anything wrong with you. And it doesn't mean that, that's the natural history of stroke recovery. It is likely to get better. And I think that is probably, and it shouldn't be misconstrued as doing nothing. Being kind to yourself and accepting that my brain and body need a bit of time to readjust. And the people I am around, my family, my friends, my work colleagues, they need to give me space to adjust as well. And sometimes when we look at the different groups who are in that supportive environment, their fatigue becomes less of a problem for them because they have been facilitated by the people they are around. And people accept them for the fact, I can't do that today. I'm going to sit down. I'm going to do whatever. Or I'm not going to sit down, but I can't do that task.
Yeah. And I guess like anything else, after you've had a big operation or whatever, your body needs, it's exhausting healing as well. It's absolutely exhausting. And for your brain to be healing from a stroke must itself be an exhausting process. So allow your body to heal, rest, and allow your body to use that energy to heal instead of rushing off to work, for example. I think that's really good advice. Okay, so that brings me, you mentioned anxiety actually in that answer, and that brings me to the next group of questions, which is about mental health. Why does there not seem to be a standard approach to mental health and support? It's such a significant life change, and the focus only seems to be on physical. And the next question, I've had a couple of questions about people whose partners have had anxiety after a stroke, and as well as panic attacks. And they think the panic attacks are more from the physical damage rather than simply being mental, like depression, etc. So what are your thoughts about that? Whether anxiety, panic attacks, mental health issues are related to physical damage or maybe the after effects of depression, anxiety, etc. from going through the trauma that a stroke produces?
Thanks,
Or
Gail.
is it a
So,
combination?
yeah, thanks, Gail. So, as well as fatigue, the other hidden symptoms of a stroke are these neuropsychological changes and cognitive changes that we see and mood disturbances. And they can be very complex and very disabling. Now, whether we ascertain that they are because of the stroke or because of the response of the brain to the stroke is rather academic. And I mean that I'm not sure it's particularly helpful to try and decipher which came first. What's
Okay.
important is to acknowledge this is how an individual feels. And that's why coming back to this concept of patients being able to be heard, to express themselves, and to say, I feel this today. I felt this yesterday, last week. I'm worried about this. And us within the healthcare spectrum, finding time to listen and to understand that how one feels, one's mood and ability to relay anxiety directly affects their ability to undertake purposeful actions in life and also rehabilitation. So we must ensure that we do link the two. And this, this happens, I'm sure, in your field as well, in gynaecology with pain. It's important to acknowledge that how an individual feels is unique to them. And we all need to listen and hear that and help that individual when it comes to, a whole array of listening therapies, talking therapies, as well as medicines can be of help for these individuals. But what's most important is that people feel heard and that we have this active dialogue to explore where these thoughts, how frequent they are, what nature they take. And part of the recovery journey for the neuropsychological sequelae post-stroke is the being heard. And so I hear some of your listeners when they say, why don't we take it more seriously? The answer is we should. Many services do. There's more we could do, though. And that interplay between psychological health and the physical aspect, we really need to get closer together and appreciate.
Okay. And further to that issue of panic attacks and anxiety, one person has asked whether there are any mental activities that their partner can do to avoid the damaged part if there's physical damage to a part of the brain. So like to bypass the damaged part of the brain that is causing the panic attack. So is it not that simple?
I mean, every
That we can
patient is
short
different, and I
circuit
think
around.
it's very complicated. What I would say is that there are behavioural therapies that are likely to
Yeah,
assist some patients, and
that's
if
yeah,
you are with somebody that you're concerned about, this is where you do need to see a professional with expertise
yeah,
in this condition to
yeah,
help tailor make a program for you, and it will often be with a listening therapy and talking therapy to start with.
yeah. And I think that there's certain parts of medicine where the care has to be so highly individualized. And I think this is one of them because there are so many variations in effects of stroke that that care has to be by a trained professional and individualized to that person. So it's really difficult to say, yes, you can do this or that exercise. It depends on what you are experiencing. It depends on your environment. It depends on your personal experience. Do you agree with that?
Oh, completely. And that's why we want individualized patient care. What works for one
Yeah.
patient won't necessarily work for another.
Won't work for the other.
You know,
Yeah.
and we've got some general rules about your vascular health, but the individual symptoms somebody has, they're theirs and they are unique, and we need to tailor therapy
Yeah.
to them as an individual.
Absolutely. Okay. Okay. So now the other questions, and they're kind of variable. So a couple of people have asked about, so I still have a burning sensation and coldness all down my affected side. Sometimes it's good, sometimes really painful. Many of us do. And this is from a stroke group, actually, that contacted me to say that many of their members have raised this issue of burning sensation, coldness down one affected side of the body. Does this ever go in time? And the second is, what can be done to lessen the neuropathy pain caused by the stroke?
So, without answering the specifics, I probably talk a bit more generally about the sensory disturbance
Generally, yeah.
that some patients
Yeah.
can have after a stroke. So there are various terms for this about central post-stroke sensory disturbance. That might be discomfort, that might be pain, that might be tingling, it might be a water sensation. What we do know is that some groups of patients are more likely to suffer with this phenomena than others. We do know that certain types of stroke it's more likely to occur in. And we also know that over time, it is likely either to become less of a problem or actually experienced less. So over time, an individual either gets used to it and tolerates it, or in fact, their symptoms become less. Now, the good news is that there are medications that can be used to assist for those patients that find it really quite disabling. What I would say is that many of these symptoms of post-stroke sensory disturbance, when patients realize that they're not having another stroke, this isn't anything sinister, this is just their brain either playing tricks with them or remodeling. Sometimes that knowledge that there is activity going on in the brain, that there is degrees of plasticity that are occurring, and one of the sequelae, the side effects of this, is this sensory disturbance. Many patients can actually rationalize that this is what's happening, and I don't need to worry. I'm not going on to have another stroke, and therefore it creates less of a problem. Now, of course, there are patients that have significant pain and discomfort, and no amount of rationalization is going to be enough for them, and they often benefit from actual pain intervention, and whether that's some of the stronger centrally acting analgesics or some of the mood altering medications. There are a group of patients that benefit from that, but on the more sensory end, just the acknowledgement that this is my brain recovering, this is me, it can help when it comes to reassurance.
Okay, so my next question, I quite like. It's from a lady who had a hemorrhagic stroke. She had seizures, and she has noticed that her seizures increase at the run up to her period. So she has taken the opportunity of having a stroke physician and a gynecologist to say, is there any link? And I can take this one.
Yeah, you take that one, Gail.
There is an entity called catamenial epilepsy, where women who have epilepsy, it can be hormonally related. We can share this one. And it can often happen just before the period as the levels of the female hormone progesterone are falling. It can also happen around ovulation when the levels of estrogen are rising, but there can be a definite pattern with the hormones of the menstrual cycle. And an option would be this lady says she's going to have the implant. An option is to give progestogens in a kind of stable manner so there isn't the rise and fall, and that might improve things. So I don't know if you think that particularly is related. It probably is related to her previous stroke, but that's the gynae take on it anyway. But it's not unusual. It can happen. It actually is unusual, but it is a defined entity that is usually treatable. Anything to add?
Well, what I would say, Gail, is that having a stroke does put you at increased risk of having a fit, a seizure,
Yeah.
And it is one of the common risk factors for seizures, which, when they become more
Yeah.
frequent, can be diagnosed as epilepsy. And of course, there's a difference between one fit or a series of fits and epilepsy. But recurrent seizures, having had a stroke, is a risk factor for that. And we also know that the triggers for seizures are multiple and variable to the individual. And there's no doubt, and I would agree with you, that variations in the cyclical nature of hormones, particularly the reproductive hormones, are associated with changes in individual seizure cycle. So again, it's about a collaborative approach with gynecologists, with some of the seizure doctors, so that an individualized, tailorized plan for that individual, reducing as many environmental or biological triggers as possible. And then ultimately, there are, of course, lots of anticonvulsants that can be used, some with minimal side effects as well. So an individualized, tailored approach and reducing triggers is probably the best advice we could give generally to patients who have post-stroke seizure syndromes.
Yeah. Yep. Okay. Okay. The next question is about, and you mentioned that, the relationship between high blood pressure and having a stroke because of a bleed on the brain, and whether there's a link between the two. And I think you've said categorically before that there's definitely a link from high blood pressure and having a hemorrhagic or stroke due to a bleed. Definitely a link, and hence why we've got to know our numbers. I like that. I'm going to use that phrase more. I'm going to steal that. Know your numbers. We need to know our numbers. Yeah. Anything to add on that, or I think you've covered it.
Gail, I can't stress how important
previously
knowing your numbers for all of us, particularly once you get over 40. We almost should be, as part of our gift to each other, what are your numbers, Gail? And we should be asking people to actually make sure that they know themselves what their numbers are. And if not, go and get checked. As of the middle of March, pharmacists for the over 40s will check your blood pressure for free.
Okay. So the next question is, so a lot of these questions are about the longer term outcome from the stroke and for the symptoms that they're having, or the things that they can no longer do that they did prior to having the stroke. This question is, I had a stroke, and since then I've had difficulties swallowing. Sometimes food or my medication will get stuck in my throat. Also mentioned the right big toenail has been purple since my stroke. So they wanted to know, I guess whether that would improve. Another is about having right side hemiplegia, so that's weakness of the right side, as well as difficulty with speech. The person does have regular speech therapy. How much time would it take normally to regain speech and writing ability? The next question is about spasticity. Will that get better? Or is it likely to get better? We can only speak in, general terms. And vision. Another one about COVID and stroke. Has there been an increase in stroke related to COVID? That's an interesting question. And again, similar question. These questions have a similar theme. Are there exercises that can be performed, to create new pathways to improve vision? Because this person's peripheral vision has been affected. So, in summary, what I'm asking about is things like swallowing, speech, spasticity, vision.
Okay, so Gail,
are they variable? So, is the answer kind of they make it?
So we've touched on this, and it comes back to this individualized approach to every single patient.
Yeah,
And
absolutely.
the key
Yeah.
terms here are experience dependent plasticity. So the things you can't do, the more you work on parts of that element, the more repetitive it is. On average, the more likely you are to regain some of those functions by allowing the brain to rewire. There are some fantastic research projects that are currently underway looking at visual and speech improvements. There are colleagues up in Liverpool and in London that are running research projects looking at both upper limb vision and speech improvements through experience dependent plasticity, that I would encourage your listeners to go onto their search engines, contact their third sector or their local stroke service and say, have you got any research projects that I could get involved in? Because there is some really exciting work with virtual mediums, with telerehabilitation, with experience-dependent plasticity, to look at ways that we can, at later stages post-stroke, so we're talking, many months or years after a patient has had their stroke, can we stimulate the parts of the healthy brain to relearn the activity of the brain that has been damaged? So it affects all of the modalities that we've got, and I think there's, this is a really rich area for research at the moment, and I would encourage lots of patients to ask about research studies. This is the way to help contribute to the things that we know that work. Secondly, to get involved in some novel therapies that may help them as an individual. And thirdly, it's a really great way of meeting other stroke survivors and healthcare practitioners that are involved in trying to make the lives of stroke survivors better. And we're all working together on this.
Okay. And again, similar questions. My right side, my arm and fingers do not move. What can I do to activate? Same answer again. So so basically what you're saying is there's no magic separate bullet for weakness, for vision, for hearing, for whatever. It's undergoing the therapy and just doing it over and over again to kind of try to retrain your brain. That's my kind of simplistic version of it.
Yeah. So of course it's a lot more complicated than that, Gail. But I think what is important, it's an individualized approach to the individual patient,
exactly,
that is tailored
correct
to their levels of fatigue, their cognitive ability,
absolutely.
their mood, their deficit, of which part of the brain's being involved, and it's tailor-made. And every patient will go through, hopefully, that individualized program about what's right for them. And that's the other thing that I think it's really important for your listeners to understand, is that this is about an individual, and they will improve at their own pace. And often patients say to me, I saw the patient opposite me, and they seemed to be able to do X a lot quicker than I could. And that affected my mood. I felt that I was less successful. Yeah. And I just say to everybody, you are different. You are you, and how you will recover, and many of you will make significant recoveries, is individualized. And what we as a healthcare team need to do is to plan things for you and to work with you to make that treatment plan yours, and be kind to yourself about your progress.
The next question is another one that capitalizes on a gynecologist and a neurologist having a conversation. They stopped I had non-Hodgkin's lymphoma and radiation to the neck, and they stopped my hormone replacement therapy, and I'm getting bad hot flashes. They said it causes a stroke. So I wanted to specifically ask this one because that's a really important question, because there's a lot of information out there about HRT and some misinformation about HRT. And we discussed this before, didn't we? That the estrogen in HRT, if you've had a stroke and you've had radiation, it's really not a viable option. I think we can categorically say that there are other ways, modalities of treating hot flushes. I don't think HRT would be sensible in that clinical situation. From the information, from the brief amount of information I have in that question. Agreed?
Well, as you said to start with, Gail,
Okay.
I think it's important that there's not, there's some general principles as opposed to this individual patient that's written in, some general
Yeah.
principles that estrogen has an association with recurrence, and therefore an individual approach is required. And so anyone who's concerned about this does need to talk it through with their local healthcare provider to discuss what's best for them, because everybody's different.
Yeah. True. Absolutely true. Absolutely true. Okay. I would like to know, this is an interesting question, why I can move the stroke side normally when I'm lying down or sitting, but not when walking. Is that common?
So, what I would say is that movement of limbs is often dependent on the contribution of gravity. So we know that gravity itself can affect the ability of an individual to lift things up or not. And when you remove gravity, in fact, the patients have movement. And so it's not surprising that when you change your position relative to the center of the earth, in fact, you can either do, and it's usually less than you could when you're lying flat, but not always. So there will be changes dependent on where gravity fits and where the deficit was, the weakness was. So it's not uncommon that that happens.
Okay. And the next question, we're nearly there, mentions about having had a stroke, difficulty with exercise. They were very active before the stroke, but with exercise and activity, their blood pressure increases, causing a headache. Is this normal? I guess they need to, again, it's individualized, and they need to know what their blood pressure is, maybe go into the GP and be monitored. That would probably be an option. It's, again, individualized care. But, I mean, if that's happening, then from what you've said, it needs to be looked into and it needs to be monitored. So advice would be go along to your GP and have a conversation about your personal circumstances. Yeah?
Definitely.
Okay. Okay. So, hi. I guess my main question would be, if we have concerns after a stroke about the area the doctor works in, where do we go for information? So where can people get information? I think that question is saying post-stroke, if they want more information, where can they contact?
Again, I would thoroughly recommend the third sector, the charities for this. So both Different Strokes and Headway and the Stroke Association have really helpful websites which have lots and lots of patient-centered information describing the sort of support offers that are available. And this would be one of the first websites I recommend patients to go to, is the charity websites, which are able and have really active and sophisticated platforms to assist patients and their carers and advocates navigate lots of the information around. And it's usually pretty much good quality information on those charity websites. So if you want a safe space to read about stroke in more detail, you can do a lot worse than going to one of the charity web pages. And I'll list those three again: Stroke Association, Different Strokes, and Headway have all got really, really important and powerful information for patients.
Okay, and again, the links will be in the show notes. Okay, so the last question, well, it's not really a question actually, but it ties in beautifully with what you were just saying. Hi, Gail. I'm a member of the Stroke Survivor UK group. I'm a stroke specialist clinical research nurse, and I run one of the only specialist stroke survivor and carer involvement groups it would be great if you could include some awareness of clinical research in your podcast and patient and public involvement too. So that just underscores what you've just been saying.
So
They want to hear from you.
Well, thank you for whoever wrote in regarding that question. So research is vitally important for us to ensure that we give the next group of patients the best possible care that is evidence-based. We also want to involve stroke survivors in how we deliver care, how we shape care for the future, and how we deliver research projects. We really do value their lived experience of the services that we offer currently, but also the research studies that we offer currently. So we are constantly looking for patient and public volunteers to help us ensure that our practice, policy, and research fits the needs of the people who use our services. This is about others using our services, and we need to make sure we tailor that for their needs.
Okay, thank you. Okay, so the last question, David, is from me. And it is that you have managed many, many patients throughout your career thus far who've had a stroke. Given the opportunity, is there anything you'd like to say to someone who may have had a stroke or worry that they may be at risk for having a stroke?
Oh, Gail, what a difficult question. So I suppose there are three things that I would say to the many thousands of stroke survivors that I have cared for in my career. And there are probably tens of thousands. Be kind to yourself and believe in yourself. Yeah. And the new you may be different from the you before your stroke. But life has value, and I hear from them that it has great value, but it's a new you. And sometimes it takes a really long time to adapt and for the others around you. And so being kind to yourself, I think, is one of the key messages I would give. And you're unique, and you will have the similar foibles and friends and ups and downs that everyone else has. It may well just be a little bit different. For those individuals who are anxious about having a stroke, I would say that stroke is preventable or delayable, not entirely preventable, but delayable for many of us. And now is the time for you to think about how you live your life and what you can do for yourself to put yourself in the best position not to suffer a vascular event, of which stroke is one, if not the most important. So that is about knowing your numbers. It is about taking regular exercise. It is about not smoking, reducing your alcohol intake, ensuring your body mass is in the normal range, ensuring that your waist to hip ratio is not greater than 0.9. You know, it's taking these measures now, because again, when we listen to stroke survivors that have had a clear correlated risk factor, they say to us, why didn't someone tell me in my, my experience with a healthcare worker that I was at risk of having a stroke? Because if they had, I may not have continued smoking, to have let my blood pressure get up to 160 systolic, to have not walked for 20 minutes 5 times a week. These small things, and although they take time, these are the things we can all do before a stroke, but also after, to reduce our risk most. And in fact, it's the collection of all those behavioural changes that actually are far superior to lots and lots of pills. And yes, pills work, but you can have as good a benefit by looking after your wider eclectic diet and exercise and social behaviour health that is free to all of us to do. And I think we probably need to help society and help each other adopt that. And that means all of us in the healthcare profession and in wider life. Let's promote that and stimulate that and look after each other to look after themselves.
Thank you. That was beautifully said. And that's exactly why I do this podcast. I'm so passionate about it because it's just so much of healthcare is education and equipping people to make the right decisions for their own healthcare. So in closing, David, it only remains for me to thank you. Thank you so much for coming onto the show and sharing your extensive knowledge and experience with us. Thank you for supporting my efforts for educating patients and the public. But most of all, thank you so much for your years of distinguished work and leadership in the arena of stroke. Thank you so much.
Thanks for having me, Gail.